Are we started?
Right, so the live streaming should be starting now. Yes.
Good morning and welcome to the Primary Care Commissioning Committee meeting, the first live streamed meeting of the committee. I'm Margaret Geary, lay member. I will be chairing the meeting today. We are meeting virtually in response to the limitations placed on governance by the COVID-19 pandemic. Members of the public have been invited to view this meeting via a link available through the NHS Portsmouth Clinical Commissioning Group website, and the papers for the meeting are also available via this website. Today's meeting is being recorded, so that in the event of a failure of technology, it can continue and will then be uploaded onto the NHS Portsmouth Clinical Commissioning Group website as soon as possible. Please note, colours have been added to the pack of papers for this meeting in order to identify agenda items. Committee members and attendees are requested to keep their microphones on mute and only to turn them on when they are called to speak. Please either raise your hands or use the raised hand function on your machines to indicate that you wish to speak. Please can I ask everyone taking part today to confirm that they are present. When I call your name, can you turn on your microphones and give your name and title? Thank you. Right. Mark Compton.
Thanks, Margaret. Mark Compton, Deputy Director of Transformation for Portsmouth CCG.
Simon Cooper. Simon in. Julia O'Mara.
Good morning, Margaret. I'm Julia O'Mara. I'm the Practice Nurse Advisor for Portsmouth CCG.
Terry Russell.
Morning, Margaret. Terry Russell, Deputy Director of Primary Care.
David Scarborough.
Good morning, Margaret. David Scarborough. I'm the Business Manager for the Trafalgar Medical Group, and I'm here today as the CCG's Practice Manager representative.
Andy Sylvester.
Good morning, Andy Sylvester, lay member.
Michelle Spandley.
Michelle's had to give her apologies this morning, Margaret. So you've got Nicola Burnett, Deputy Chief Finance Officer, deputising for Michelle this morning.
Okay, thank you. Roger Batterby. Barry.
Hello, Margaret. It's Roger Batterbury, Chairperson at Healthwatch Portsmouth. Thank you.
Sylvia Macy.
Morning, Margaret. Sylvia Macy, Primary Care Estates Programme Manager for Portsmouth CCG.
Jo Hans-Rensie.
Good morning, Margaret. Jo Hans-Wenzel. I'm NHS England Primary Care Commissioning Manager.
Thank you. Lisa Harding. Lisa on. Justina Jeffs.
Good morning, Margaret. My name's Justina Jeffs. I'm Head of Governance at the CCG.
Steve McGuinness.
Morning, Margaret. Steve McGuinness, Primary Care Relationship Manager for Portsmouth CCG.
Stephen Orobio.
Morning, Stephen Orobio, Clinical Quality Manager for Portsmouth CCG.
And Lisa Stray.
Lisa Stray, Business Services Minute Taker.
Thank you. Okay.
Margaret, you've also missed myself. Morning, Nick Moore, GP Clinical Executive on the CCG.
I think I thought I'd read your name out earlier. Sorry, Nick. Okay.
Thank you.
Okay.
Hi, Margaret. I'm also attending. It's Joanne Williams, Acting Director of Medicines Optimisation. I'm here for Simon Cooper.
Sorry, Joanne. Thank you. Thank you very much. Is there anyone else attending the meeting that I have missed? No? Thank you. Okay. Can I then move to the agenda? We've had a number of apologies They include Jackie Powell, Dr. Helen Atkinson, Joe York, Jason Eastman, Christine Horn, and Rebecca Standing. I'll just welcome you to the meeting and just ask if there are any declarations of interest, any conflicts of interest that people know they have in the agenda items today. No? Okay, shall we move on? Can we move then to
Sorry, Margaret.
Yeah,
I
sorry.
think there's a couple of hands up.
Okay, thanks, Mark. Conflicts of interest?
Yeah, Margaret, it's David Scarborough. Yes, I've got conflict of interest. Neighbouring GP practice in the city.
Okay. Any other conflicts of interest?
And there's Dr. Moore as well.
Yeah, I mean, as a practicing GP in the city, obviously I have conflicts of interest. It usually runs throughout a lot of the meetings, although not specifically related to any of the particular items today. None of them relate to my own particular practice as far as I can see.
Okay, so neither of those conflicts are direct conflicts of interest at present, so you're allowed to participate in the meeting on that basis. Okay, thank you. Can I then move to the minutes of the previous meetings? Can we just deal with them for accuracy at the moment? Page 1. No comments. Page 2. Page 3. And page 4. And are there any comments or questions? No.
Nick, can I just confirm, because you've got your hand raised, I don't know if it was left over from the declaration of interest.
Apologies, I've moved it. Sorry.
Okay. Can I then move to the action, which was that we have the full financial report to be shared with the committee on this agenda, and it's on the agenda today. Okay, thank you. Then can I move to the primary care risk register? Are there any? Does anyone want to comment on that? Terry, do you want to say anything about that?
No, I think the risk register is the same as the risk register that was previously presented. I don't believe there are any new risks, although arguably a lot of those risks are certainly being actively managed still, particularly around coronavirus and practice's ability to deliver services safely and the full range of service. So no new risks, lots of additional mitigations being put in place, very much working across our system to make sure that happens.
Okay, thank you. Can we, any comments on that? Any questions? Take silence. I mean, there isn't. Okay, thank you. Can we then move to the primary care, to the Guildhall Walk paper, please?
Yeah. If you just bear with me while I get up on my screen. So all committee members will be aware we currently have a APMS contract which is held by PHL within the city to deliver primary medical care services from the site in Guildhall Walk. And this is really a question of the committee to agree the proposal to utilise our optional one-year extension. So as you'll see from the paper, when we initially let the contract, it was for a 2-year period with an option to extend for a further year. I think people will fully appreciate the situation we're in currently, that I think makes any radical changes quite difficult to do. I think we would want to ensure that any changes we were proposing or even extensions we were proposing in terms of a longer term contract, we'd need to understand public views, and we'd need to understand the kind of broader strategy within the city And those kinds of activities are very difficult to do at the moment. So I think it is prudent and sensible of us to utilise our optional 1-year extension to that contract, so that hopefully as things become a bit easier, we'll be able to carry out kind of comprehensive activities to understand what the future of that site and any options that we might have around the contract are. Happy to take any questions.
Are there any questions or comments?
No hands raised at the moment.
Okay. Sorry, can I go into the public? That I'm on an iPad and cannot see the hands raised signal. So Justina is helping with that. Okay, thank you. Okay, if there are no comments, are people happy to approve? And I think you're going to have to put your microphones on for this. But are you happy to approve the 12-month extension?
Approved.
Yes.
Yes.
Okay.
Yeah.
Yes.
Yes.
Yeah.
Thank you. That's fine. Thank you very much.
Thank you.
Can I move then to the next item, which is the primary care finance report?
Could I just ask a question, Margaret? I do apologise coming in late on it. Just in terms of, obviously we're extending for a year, then what is there obviously following off this proposal as to what we're going to do then in a year's time? Is there going to be then a consultation process? Is that going to lead on? I know it's not specifically referenced in the paper.
Yeah, so what we would intend to do, Nick, is obviously utilise the 1-year extension, which takes us to the end of September next year. That gives us adequate time to understand what the needs of the population are, to understand what options we've got, also to understand how things are developing, for example, around primary care networks and other services within the city. So it gives us time to carry out a proper exercise and to make sure we commission whatever is necessary.
Great, thank you.
Okay, thanks for the question. Any other comments or questions on that? If not, can we move to the primary care finance report? And I think that's Nikki.
Bear with me 2 seconds, Margaret. I'm just trying to switch between screens to get the paperwork up. Yeah, apologies about that. I've got it here. So what this is a representation of the finalised position. Now the CCG has completed its audit of 2019-20 across primary care. So what you can see is there were some underspends as we'd anticipated through some of our schemes. However, a lot of that was due to the schemes being 2-year schemes, but we built in the maximum potential expenditure for the year to allow practices to develop, particularly across the sequence scheme, at a pace that suited them, rather than adding any restrictive elements to that. I wasn't particularly planning on going to anything in detail, unless anyone's got anything by exception they'd like to ask any questions on or not.
Are there any questions? Are there any hands up?
Yeah, David has got his hand up.
Dev?
Yeah, hi. Can I just ask about the COVID costs? Obviously, there is a notation on the summary of COVID costs in the small box at the bottom. Because this is a budget statement for 2019-20, so that's the COVID costs up to the 31st of March. Am I correct?
That's correct, Dev. As we sort of continue working through COVID, we're still waiting absolute clarification nationally on how the funds will work sort of in entirety, but all of the claims that we put through in 1920 have been reimbursed to practices and have been reimbursed nationally back through the CCG. So as far as we're concerned, for 1920, the COVID expenditures concluded at this point.
Okay, thank you. That's what I thought it was. But just going forward, into the new financial year. Is that the same? Have claims to date that have been put in been refunded nationally as yet, or is that still waiting for the more detailed guidance that we're expecting to come in nationally with regards to COVID funding?
So no, that isn't the case at this point in time for 2021, Dave. Sort of referring to the full financial position statements that go via sort of the governing board, what you'd see is that currently the CCG is in deficit, and that is due to the fact that we have outstanding reimbursement claims nationally as they work through how that reimbursement mechanism will work. We have been given assurance that at least for month 1 to 4, all of those sums should be reimbursed to us in full. However, we are still awaiting month 5 to 12 guidance around the financial architecture for the NHS for this financial year. So still a little bit of uncertainty. But where we have assurances from practice is that we're happy that their spend aligns with the spirit of the guidance as it is, have made the reimbursements to practices. So the risk is currently sat with the CCG as opposed to cash flow issues within practices at the moment.
Okay, thanks, Nicola. That's very clear. Thank you.
Okay, any other questions? Any other hands up? Can I ask a question here, which is about and I'm not sure I've understood it properly, but the variation, there seems to be a significant variation on workforce development, just to explain that.
So workforce development is an allocation that came through around month 11 or 12 of the year nationally. And so at that point in time, because of the way that the CCG works practices to allow them to invest the money as they see fit, we weren't able to fully commit that monies in year. But what we have done is safeguarded that money into 2021, and between Terry's and the finance team, we're working with practices to ensure that those funds are invested with the intended purposes of those allocations over a more appropriate time frame, as opposed to sort of rushing at the end of the year and maybe not getting the benefits that we wanted through those schemes.
Okay, thank you. It's important that it was secured. But, okay, thank you. Any other questions? Comments? No? In which case, can we just note that report, please, and move on to premises improvement grant. Sylvia.
Morning. So NHS England allocates capital funding for premises improvement grants on an annual basis. However, funding isn't guaranteed and it can vary considerably from year to year. So usually practices make bids for funding in line with the premises cost directions, and there's a prioritisation process and an allocation which is usually confirmed by NHS England. In 2018-19, the premises improvement grant funding was based on a fair share allocation across the STP, and NHS Portsmouth CCG received funding for 11 bids from 7 practices. All improvement grants should have been completed in year, but due to a number of issues, the bid from the Drayton surgery, which was for the expansion of 5 clinical rooms, is still ongoing. Completion is expected in January or February 2021, which will give the practice the much needed clinical space. That's for that year. Premises improvement grants for 2019-20. So there were 10 schemes from 4 practices supported by the CCG with an allocated funding of 92,000. Again, schemes were expected to be delivered in year, but due to COVID, there were some delays with the schemes progressing. And they are all now taking place, and we expect them to be done within this financial year. Premises improvement grants 2021 to 2022. NHS England requested bids for the 2-year period in December 2019, and practice submitted bids accordingly. For 2021, there were 10 bids from 5 practices submitted, but in June this year, NHS England informed the CCG that only 1 bid had been prioritised. The CCG has responded by requesting that 4 schemes are reconsidered with funding for this financial year, and we're currently awaiting a response from NHS England regarding this year's improvement grants. So it's really just to update the committee on the process and where we are at the moment.
Okay, any questions, comments? No, no hands up. Okay.
I've got Mark, I've got Terry, Nick and Dave.
Thanks, Justina. Can we have Mark?
Thank you. Thanks, Sylvie. That's really helpful to see it. My question was just in relation to the Drayton development. Obviously, that's from 2018, and I understand they had a number of setbacks which has delayed it. I just wanted to test the confidence that we have that it will be carried out this year, given the impact of COVID, etc. Are we quite confident that those works will be undertaken and completed this financial year?
Yeah, it's literally going on as we speak, and the practice are confident it will be finished early next year.
Thank you.
Okay, Terry.
Yeah, my question was, I'm not sure she would have done, but Nikki, have you heard any more from Region about when or whether we're likely to get our funds this year? I think it's really important. I appreciate we're in a slightly tricky position at the moment and things aren't necessarily happening as quickly as possible, but the year will fast disappear, won't it? And we know how difficult it is. Drayton's a case in point, isn't it, to get these schemes up and running, and these are actually quite significant schemes, particularly for a couple of the practices. So do we know, have we got any kind of timescale from Region on when we're likely to hear about the funds?
So the short answer to that one, Terry, is no. We have, so last Friday we had a forum across FDs across the whole STP, including NHSI and E, which majored on capital, both looking at provider and CCG capital, because there's a whole host of issues that are transpiring at the moment due to the delays in us getting confirmation around our ability to proceed with projects that we've prioritised and had sort of initial signals that are signed off. Whilst that hasn't given us a conclusion to date, it has sparked off a working group that is now being set up between NHSEI in the region and the STP to really highlight to them all of the risks across the whole system of these delays and the consequences of that. So I'll choose my words carefully because I don't want to sound too optimistic, but you know, we're doing the things that we can to highlight this, but unfortunately the issue seems to be at Treasury rather than regional level, and until that's unlocked and we don't have too much of a sway to unlock that, all we can do is keep sort of banging the drum. And we're certainly sort of making quite a lot of noise sort of up the line, both for ourselves and for some of our neighbouring CCGs who are also having particular difficulties with schemes being compromised potentially due to delay. So no, completely understand your point, and it's definitely not lost, and it's certainly been escalated, but unfortunately we don't have a date yet for which they're going to confirm that we can start utilising those funds.
Thank you.
Okay, Dr. Moore, do you have a question that's not related to your own premises?
It is, yeah. It's not related to my own, but it was related just to the reason for why it has been delayed. Is it because there's a substantial difference in the amount that's being bid for this year? Because obviously it's significantly more, isn't it, this year than previously? Is that the reason why, or is it just to explore why there's been that delay, really?
No, so we've not bid for more than we've bid for in the past this year, Nick. The issue is nationally, because of COVID and because of a number of other issues, the allocation of capital has been compromised. So what they keep having to do is revisit how much is available in each pot. And then because they've already pre-approved the original bids against the pots, they're having to continually keep going around the system for each individual category of capital and try to renegotiate with systems a reduced ask. And as I'm sure you can imagine, across the country, that renegotiation bears different results each time, which never particularly solves the issue. So really, until we're really clear on how much COVID's going to cost, what the financial regime is, I'm not particularly hopeful that we're going to have the answer on capital, because the revenue and capital transfer is really relevant to this, and it's capital into revenue that's the priority. If you look at sort of the figures that were in the NHS England board papers this week around COVID spend to date, the figures are far higher than I think anybody expected, which is why they're just sort of pausing approving things until everybody's really sure of where we're going.
Can I just clarify? Can I just clarify though, because the number for the last year was a total of 91,710, and this year it's 221,000. So it is significantly more, isn't it? Or have I misunderstood the papers?
So in total, the CCG's business as usual capital request is not more than it was last year, and our request is in line with the indicative capital allocation we've been given. It's just that nationally they're unable to physically approve and transfer that capital to us. We have had sort of the initial green light on the majority of our schemes, but they can't officially tell us we can proceed until all capital issues are resolved, which leaves us in this really frustrating position.
So Nick, capital doesn't just include the premises improvement grant bit either. So I think it's broader than just premises improvement grants. But this is displaying to you premises improvement grant bids.
I see. Okay, that's why I was querying it, because obviously they are different amounts, aren't they? That's fine. Thank you.
Okay. Dan, Dave. Dave, do you have a?
Yeah, sorry, Margaret. I'd actually taken my hand down because Terry covered most of mine. But the only thing to add to that is that but the answer's all there. Is the urgency is that 3 of those 4 projects are for additional clinical space within practices, and that is of great importance to those practices at the moment. But Nicola's given us a comprehensive answer of when we'd likely or not to get a response. So it's covered. Thank you.
Okay, thank you. Any other questions or comments? Any other hands up? No.
No.
And we then note and this particular paper. Okay.
Noted.
Thank you. Thank you very much. And move on to healthcare assistant preceptorship framework. Julia.
Yes, thanks, Margaret. A slightly different theme now with my paper to the meeting, but my role is to support workforce, but most importantly to ensure a competent and safe workforce for delivery of patient care. So the background to this paper is that ordinarily if a healthcare assistant, who is an unregulated member of general practice, joins a surgery, I would normally offer sort of an induction process or support with an induction process. And that may involve actually visiting the practice itself, seeing the healthcare assistant and going through their individual training needs analysis, and then actually signposting them to face-to-face learning, which of course at the moment, lockdown with COVID changed all the dynamics of that. We know that in Portsmouth, we've recruited 3 healthcare assistants in the city during lockdown, which is fantastic, but their actual induction process is entirely different to how that would have been. And we need to ensure a safe induction process and preceptorship for them. Having shared this with the other forums that I attend, such as Health Education England, the LMC, the Learning Hubs, and all the kind of forums that are related to my role, I found that actually this isn't just a problem in Portsmouth City, it's been identified as an unmet need elsewhere across the whole of Wessex. And actually, having presented my paper at the Wessex Practice Nurse Forum group, the director of Health Education England for Practice Nursing, Pippa Stupple, wanted to share my paper with a lady called Karen Story, who is actually the primary care nursing lead for NHS England. So she actually wanted to ask for it to be a national paper where obviously it would go through peer review and quite robust evaluation. Clearly, I needed to get the authority from this group and anybody that wanted to sort of comment on it, to make any changes, to make sure that you were happy with giving me the authority to share it wider and also to use it as a tool in Portsmouth City. So it's a 25-page document. I don't know if anybody's had a chance to look at it and if you understand much about nursing and healthcare assistant. But basically, it goes through things from the care certificate, which we identified, was a need when through Mid Staffordshire, really. That was one of the things that came out of Mid Staffordshire when nurses had to revalidate. The care certificate was something that was signposted for healthcare assistants to be a good framework for ensuring safety. So it talks all about the care certificate, how to get onto the care certificate, what the assessor needs. I then talk about accountability and delegation. It's really important that healthcare assistants know, about vicarious liability and how they're legally responsible for patient care that they deliver, even though the registered nurse is the one that actually is accountable for delegating that to them. They need to know that they also have a duty of care to that patient. And then I look at the training needs analysis, and I actually developed a framework here for the assessor. We like to call them assessors now as opposed to mentors. And the training needs analysis looks at what they already may have with their skills, because we have to recognise general practice is very unique for healthcare assistants, and they may have come across from district nursing, community nursing, or they may have been employed in Tesco last week. So some people will come with transferable skills. And so therefore this framework that I've developed was what I've taken it from the framework when I developed the Practice Nurse Foundation course 10 years ago for Bournemouth University. And so I'm using the same kind of tools really. This framework looks at if they have already experience in wound care, then maybe they worked on the community, then actually that wouldn't be a massive priority for them to have that learning. So they're able to look, it comes from a scale called the Nancy Benner, which is a novice to expert really. They're able to look at what areas they feel they may be a novice in, but also underconfident in themselves, and what areas they actually already bring something to the table and just need those updates. So that helps the assessor in general practice to look at their individual needs. And then from page 8, we're looking at the knowledge and skills obtained within induction, but also at specific clinical competencies that are unique and relate to general practice, such things as ECGs, removal of stitches and staples, phlebotomy, and chaperoning, which clearly is a quality skill that you need to be able to safely ensure that the patient has their rights within an examination. We then talk about whether that training can be a formal training or whether it can be in-house. And this helps the assessor who will be looking at this document decide, can I provide some of that here? Or, do I actually need to signpost my HCA to an e-learning course, or maybe identify a formal face-to-face course? But essentially identifies the need for competency, which is so important for HCAs. The competency frameworks that I've included in this document, starting from page 11, are the very basic ones that the assessor in the practice can help to facilitate, and that then also goes on to talk about some more formal. So starting off on things like health and safety, moving through to sort of chaperone, hand hygiene, then I think it goes into just some of the clinical skills around measuring height, weight, recording a pulse, things that we take for granted, but actually we need evidence of these. We need sign-off documents for CQC, but for the actual healthcare assistant themselves. Sharing this with a couple of my healthcare assistants on our forums, they've said, why didn't I have this? So I feel a bit guilty around that, really. Should have put this together years ago. And then the specific education for healthcare assistants on page 22. I work closely with my Fareham and Gosport colleague, a nurse advisor in the same role as me, and they've actually developed a really good essential skills booklet, which is electronic, so it's continuously updated. The HCAs can go into that, or in fact any person in general practice can, and it identifies where they can obtain their courses, so whether they can get them e-learning or whether they can go to specific colleges for them. Finally, on page 23, I work closely with our Learning Hub lead, Annette Farrell, to put this page together. And this was about career development, because when you join general practice as a healthcare assistant, unregulated, some people may feel this is fine, I can consolidate my practice, I'm happy providing this level of care to patients, but others may want to advance. And there's opportunities now, fantastic opportunities to become a level 3 HCA, complete your QCF, which used to be the NVQ, or in fact a nurse associate or a nurse apprenticeship course that we can provide now with funding through healthcare, through Health Education England. So there's a really good opportunity there for them to develop the sort of things that they don't always know about, or perhaps their assessors in practice don't know either. So I think it's useful to have a tangible document to be able to refer to. And then obviously it just finishes with references. So they can have that document electronically, complete it and use it as they like, really. It's not a policy, it's just really a tool and a guide to help them with their practice nurse journey or their healthcare assistant journey into general practice. So really, I just wanted to ask for comments and views on whether you feel this would be a useful document, and your permission to share it wider across Wessex and nationally. So I'll pause there.
Okay, any questions or comments?
Yeah, we've got Terry and Nick.
Terry?
Yeah, so firstly, I just wanted to congratulate Julia, because I think this is a really excellent document, and I think the fact that they're asking if this can be shared nationally is kind of recognition of your hard work and your experience. And I think, arguably this is a vital document for our healthcare assistants. You're talking about an unregulated workforce. Absolutely. We've always prided ourselves, haven't we, on focusing on quality and support. And it's just made me think, actually, I think there's a new risk, and I'll work with you on it, Julia, around training and expertise, because we've not specifically singled that out. But particularly at this moment in time, it's a real risk, isn't it? Access to training, access to that kind of support. And I'm just thinking more broadly as well, and perhaps not a conversation for now, but we know there's been impact on the broader workforce within general practice around our target sessions, and the potential for those to be impacted in the future as well. So just set a light bulb off for me. I think we need to put together a risk around access to training and the ability to really engage in that work at the moment.
Yeah, thanks, Terry. I think you're absolutely right, and that clearly is what gave me the impotence to write this paper, because I had so many emails from the new HCAs that were sort of joining general practice. Where can I go? What can I do? Can I get on this course? And of course, as you said, during COVID, all the face-to-face courses were completely shut down, and there was a gap there. And I was actually quite surprised that people were still recruiting, because it's a challenge too. And clearly, the actual way that they're working in general practice now is different to how it was before. So we need to have a different system going forward, and something that they could tangibly start with in practice with their assessors, but absolutely after that, where do they get, what's the next steps, and how do they access that? Yeah, I agree.
Okay, Nick?
Yeah, just to echo what Terry said, but I think it's really, really good. And I think, although you say it's however many pages it is, I think it's actually pretty concise. And really, really good structure. And I think I would just support it. I think it's really good that you've got, it's a really user-friendly sort of document, really. And I don't have any improvements or suggestions. I just would say I would really support it. So that's all I have to say, really.
Brilliant. Thank you very much. Great. I'll share it.
We've also got Dave and Roger.
Dave?
Dave, you're on mute.
Sorry, through technical issues. Just very briefly, I echo everything that Terry says. From a practice manager perspective, I think this is brilliant, and I would really welcome it to have, you know, a clear document and framework that you can recruit a brand new HCA against. So, yeah, great. I'm really pleased that something like this is going to come out.
That's lovely. Thank you, Dave.
And then Roger.
Thank you, Julia. A great document. I have read all the pages. I haven't used all the links, but I've read all the pages. A couple of questions. Is there a time frame to implement? So is this, you know, going to be implemented as of, if we all say yes now? And is it aimed for current staff or just new staff? But it's a fabulous document, and as somebody that has in the past employed registered and unregistered staff, wished I'd had it all those years ago. So well done.
Yeah, thanks, Roger. I know I've been a bit reactive to our healthcare assistant workforce, and I think it wasn't until COVID, when I realised I couldn't see them face to face, that actually made me, you know, think about this document. But in answer to your question, so the care certificate, they usually recommend sort of that you actually complete that within 12 weeks. And that's all embedded within the document, because that's the sort of standard induction for the care certificate part of this document. But actually, no, there are existing HCAs out there that haven't had a formal induction or preceptorship, which is a requirement for the organisation. So some of them will probably use this as evidence in their portfolios retrospectively. You know, they'll go back through those competencies, even though they may be quite competent at testing urine. It will be useful to actually say, well, actually, let my assessor, my supervisor watch me. I can explain what ketones mean. I can explain what protein means. Get that signed off, but actually have that as evidence in their portfolio. So we're suggesting brand new, but also existing HCAs that haven't had this robust evidence to start using it and start acknowledging and evidencing what they're doing, because we've got some exceptionally good HCAs out there, but if it wasn't written, it wasn't done, is what we say. So
very reassuring. Thanks, Julia.
Go back to it. Thank you.
Yeah.
Any other questions or comments? Sounds like an excellent paper. It's been much needed by the sound of it, the consensus is. We are being asked to agree this, so can you turn your microphones on again and just say whether you agree that this is a paper that should be used in Portsmouth and shared more widely?
Yes.
Yes, definitely.
Overwhelming agreement there, Julia.
Thank you very much.
Thanks you very much. Well done. Okay. I think that brings us to the end of our business for the meeting, unless there is any other issues people want to raise. No? Okay. The date and time of the next meeting is the 24th of September 2020, and we'll close the meeting at that stage. Okay, thank you.
Thank you.
Thank you, Margaret.